During this lecture, we will discuss intracellular accumulations of different substances, calcifications, and cellular aging. Substances can accumulate inside the cell due to different mechanisms, and these substances may accumulate in the cytoplasm, in the organelles like in the lysosomes or in the nucleus, depending on the type of the material that is deposited. And there are mainly four mechanisms for deposition of these materials. The first one is that the material is a normal endogenous material, but it is inadequately removed or inadequately degraded from the cell, like the fatty chain that occurs in the liver. The second mechanism is an accumulation of an abnormal endogenous protein due to defects in the folding of this protein, leading to accumulation of a misfolded proteins, which we talked about it in the endoplasmic reticulum stress in previous lecture. One of the examples on this is the alpha-1 antitrypsin deficiency disease. 3. Failure to degrade a metabolite due to deficiency of the enzyme needed to degrade this metabolite, and the best examples on this is lysosomal storage diseases due to lack of certain lysosomal enzymes due to a mutation, a genetic mutation, which lead to accumulation of substances inside the lysosomes. Fourth is deposition of an extracellular exogenous material that comes from outside and gets deposited in the cell, like the carbon deposition in the lungs and the silica deposition. So these are the main four mechanisms of accumulations. This picture summarizes what we have said. The first one shows the deposition of an endogenous material due to abnormal metabolism, inadequate removal, for example, like the fatty liver disease, deposition of triglycerides inside the liver cells. The second mechanism is due to a defect in the protein folding and transport, and this usually results from a mutation at the genetic level. This leads to production of excessive amounts of proteins that are misfolded, so these proteins will accumulate in the cell, and an example on these is the alpha-1 antitrypsin deficiency. The third mechanism is like lack of enzymes that degrade a complex substance to a soluble products. This lack of the enzyme is also genetically inherited most of the time, leading to accumulation of these substances, mostly like here in the lysosomes, like in lysosomal storage diseases. And the fourth mechanism by deposition of an exogenous material inside the cell, like what we see in deposition of carbon in the lungs. The first example is fatty change or fatty deposition, which we call it steatosis. Steatosis. It's most commonly seen in the liver because it's the most common organ involved in fat metabolism, but also it can be seen in the heart, kidney, muscles, and even other tissues. It is due to deposition of triglycerides in the cells, and as you can see here, the triglycerides or the fat deposition is manifested by these white fatty droplets inside the cells that vary in size. Some of them are macro and some of them are micro. The causes of this deposition can be due to toxins, if you remember the carbon tetrachloride toxicity, protein malnutrition, diabetes mellitus, obesity, and anorexia. Now, alcohol abuse and diabetes associated with obesity are the most common causes of fatty liver disease in industrialized countries. The second deposition is deposition of cholesterol and cholesterol esters, and the most common site for deposition is in the walls of the blood vessels. The fat is deposited like you see here in the wall, that is the yellowish color. It is uptaken by the phagocytes and or macrophages in the walls of blood vessels. They become overloaded with these lipids that are the triglycerides, the cholesterols, and cholesterol esters. And the cause is either there is increased intake of these esters or decreased catabolism of these cholesterol and cholesterol esters. The best example, as you know, is the atherosclerosis, which can predispose to coronary heart disease or cerebrovascular accidents. Now, deposition of proteins is much less common than lipid accumulations. Proteins can be derived from inside the cell, produced inside the cell, or derived from outside the cell. Like examples is the deposition of proteins in the proximal convoluted tubules in the kidney in patients اللي عندهم nephrotic syndrome. هذول nephrotic syndrome they lose albumin in the urine, and normally when trace amounts of albumin is excreted, they are reabsorbed by the kidney tubules وبيرجعوا لبلد مرة ثانية. في حالة nephrotic syndrome there are excessive amounts of proteins that are lost in the urine. So as you can see here, these pinkish droplets inside the epithelial cells of the renal tubules are proteins that are reabsorbed from the urine in order to return them to the blood, but because the protein amount is high, they take this discoloration. Another example, as you can see here, these are plasma cells with excessive amounts of immunoglobulin production, so they get deposited as these pinkish droplets inside the endoplasmic reticulum of the plasma cells. Another examples on protein depositions is the alcohol hyaline material in the liver cells in alcoholic patients, and the neurofibrillary tangles in the neurons of patients with Alzheimer's disease. All of these are proteins. Another example on endogenous accumulations is the accumulation of glycogen. Now, a glycogen is accumulated due to a defect in the metabolism of a glucose or a glycogen, like in patients with diabetes mellitus, in which glycogen and the glucose are deposited in the renal tubular cells, in the heart cells, and in the beta cells of the pancreas. And another example on disease in which there is deposition of glycogen is the glycogen group of disorders. We call them glycogen storage diseases, in which there is an inherited abnormality in the metabolism of a glycogen. So we have, like in this picture, deposition of glucose and the glycogen in this picture is from the liver. You can see how a faint pink color the glycogen color is. Now let's move to pigments. Pigments are colored materials or substances that can be derived from intracellular compartment or exogenous from the cell. Examples on exogenous pigments, the most common one is carbon, or which we get it from air pollution or coal dust. Carbon is ingested by alveolar macrophages, then it is carried by the lymphatic canals into the brachybronchial lymph nodes, giving them the blackish discoloration, and also under the light microscope we can see the carbon pigment, as you can see here, a black granular pigment inside the macrophages, and we call this in the lung anthracosis. The second pigment is endogenous, and we call it the lipofuscin pigment. It is considered the wear and tear pigment due to the cause of its deposition. It is said that it is accumulated in cases of aging and atrophy of the cells. Usually the tissues that develop lipofuscin deposition in aging or atrophy are the heart cells, liver cells, and brain cells. Lipofuscin material is composed of lipids and proteins, and the presence of this material, which is usually have this brown yellow discoloration, granular pigment, as you can see here in the cardiac muscle cells. It is an indication of a previous free radical injury to the tissue with resultant peroxidation of the membranes and damage to the lipids in these membranes. When the tissue develops or deposits excessive amounts of lipofuscin pigment and turns brown in color with associated atrophy. We call this brown atrophy. Another endogenous pigment is the melanin. We all know that melanin is produced by melanocytes present in the skin, and it gives the skin its color. When melanin is deposited in large amounts, the skin color turns deep in color, and when it is present in small amounts, the patient or the person have a fair-colored skin. It offers this melanin produced by melanocytes offers protection against ultraviolet light, and usually it accumulates if it accumulates in excessive amounts. It accumulates in the dermal macrophages and in the adjacent keratinocytes, as you can see here in this microscopic picture. It is deposited here in the macrophages of the dermis, giving them this brown discoloration, and as you can see here, in addition, it is also deposited in the keratinocytes at the basal cell layer of the skin. Excessive deposition of this pigment characterizes the freckles that we see in fair-colored skin people after exposure to sun. Another pigment is the hemosiderin, which is a hemoglobin-derived pigment, granular, brown in color. Iron is usually deposited in tissues is stored in tissues by binding to apoferritin. So the iron, when it is bound to apoferritin, it forms ferritin micelles. Now, when we have an excessive deposition of iron, we have an excessive deposition of these ferritin micelles in the tissues. As you can see here, the color of the iron pigment or the hemosiderin is brown in color with a granular appearance. Now, iron can be deposited in physiologic conditions or in physiologic ways in the tissues that have a rapid red blood cell turnover, like in the bone marrow, for example, in the spleen or in the liver, and in these tissues it is deposited in the macrophages or the phagocytes. But also iron can be deposited in pathologic conditions, can be localized, like in cases of bruises after a localized hemorrhage, or can be deposited in a generalized pattern or systemic pattern. We call it hemosiderosis. And hemosiderosis can result from hemochromatosis, a genetic disease, or from certain hemolytic anemias like thalassemia, sickle cell anemia, or in patients taking repeated blood transfusions. How can we make sure that this brown pigment in the liver, for example, as here, is an iron pigment, not lipofuscin pigment, not a melanin pigment, for example, even in the skin? By staining it with a Prussian blue stain. The Prussian blue stain it gives us the blue color of these granules if it contains iron, but if it is lipofuscin or melanin, it will not take this stain. Now we come to deposition of calcium, which we call it calcification. It is an abnormal deposition of calcium salts together with small amounts of iron, magnesium, and other minerals. And we have two types of calcifications, the dystrophic calcification and metastatic calcification. Why it is called dystrophic calcification? Because the deposition occurs in dead or injured tissues, not in normal tissues, and it is usually associated with a normal calcium levels in the blood and normal calcium metabolism. That is, it is not associated with hypercalcemia, but it is exacerbated by hypercalcemia. The other type of calcifications is metastatic calcifications. It is a misnomer because it has nothing to do with the malignancy, because we know that metastasis معناها انتشار المalignancy، انتشار المرض الخبيث أو انتشار الكانسر. It has nothing to do with the metastasis or with malignancy, but it is a misnomer. It indicates the deposition of calcium in normal tissues, and it's almost always associated with an abnormal calcium metabolism, that is hypercalcemia. So in dystrophic calcification, it is the deposition of calcium in tissues with necrosis or tissues with damage of any type, like deposition in the walls of blood vessels affected by atherosclerosis, in the aging or damaged heart valves, which can lead to, as you can see here, the deposition of calcium here in the aged aortic valve, like you can see here, leading to aortic stenosis and deposition of calcium in areas of inflammation like tuberculosis. Sometimes incidental finding، يعني incidental means إنها الشغلة بنلاقيها بالصدفة. Of a dystrophic calcification indicates إنه كان في previous insignificant past injury at this site. If the dystrophic calcification deposition is excessive, it can be associated with organ dysfunction. But if it is of minimal amount, it cannot be associated with organ dysfunction. Now, regarding metastatic calcification, as you can see here, it is characterized by the under the microscope, under the light microscope, calcium can be seen as this purple color, but macroscopically or grossly, as you have seen in the previous slide in the aortic valve, it gives a whitish, chalky color. Microscopically, it is a purple color, as you can see here, and metastatic calcification, the surrounding tissue or the tissue is normal. So it is deposited in normal tissues, not in damaged or aged or injured or necrotic tissues like in dystrophic calcification. The causes of metastatic calcification are any cause that is associated with hypercalcemia, like hyperparathyroidism, whether it's primary or secondary hyperparathyroidism, which can occur in renal failure, or the production of parathyroid hormone related proteins, like what occurs with certain malignancies. Bone destruction of any cause, like metastasis, Paget's disease of the bone, multiple myeloma, a tumor of the plasma cells of the bone in the bone, and leukemias, immobilization. Vitamin D intoxication also can result in hypercalcemia. Sarcoidosis is known, it's an autoimmune disease, and it is well known to be associated with hypercalcemia. The deposition of calcium occurs in different tissues, in the vessels, in the lungs, in the kidney, but these tissues, as I said, are normal. Now, the last topic that we will talk about is the cellular aging. Apart from the cosmetic consequences of aging, aging is one of the strongest independent risk factors for many of the chronic diseases that we know, like Alzheimer's disease, ischemic heart disease, for example, and certain cancers. Aging is associated with a progressive decline in the lifespan of cells، يعني فترة حياة الخلية بقل، وأيضا ال functional capacity of the cells وقدرتها على القيام بوظائفها الحيوية. There are many mechanisms, several mechanisms for cellular aging. The first one is accumulation of mutations in the DNA. And these mutations usually accumulated due to exposure to radiation, ultraviolet light, different toxins, different causes that lead to accumulation of these mutations. We know that the normal cell can repair any damage that occurs in its DNA, but with the aging of the cell, this capacity is decreased. So this will lead to accumulation of different mutations that will lead to decrease the functional capacity of the cell and decrease its ability to replicate. The second mechanism is decreased cellular replication. Now, somatic cells, they proliferate for a certain number of times before they enter into the arrest and the cell cycle, and we call this the replicative senescence. Replicative senescence. It is a progressive progressive decrease in the number of divisions that a cell can underwent. Now, every cell has a certain number of times. We are not talking about stem cells here. We are talking about the somatic cells. they have a limited number of times that the cell will replicate or divide, because we have something called a telomere. The telomeres, these are short repeats of DNA at the ends of the chromosomes. Their function is to protect the DNA material, the coding material of the chromosomes at both ends. These telomeres are usually kept in their normal length by an enzyme called telomerase. Now, the activity of this telomerase decreases when the cell ages. So, the length of the telomeres at the both ends of the chromosomes will be shorter. This will let the cell sense that the DNA at both ends of the chromosomes of the chromosome is exposed، وبالتالي ممكن يصير له damage إذا صار في عندي further replication، فبيخلي الخلية تدخل في السيل cycle arrest, and we call this replicative senescence. The third mechanism is by defective protein homeostasis. With aging, the cell ability to produce proteins decreases, and protein degradation increases. So the end result is a decrease in the amount of proteins inside the cells. Also, the aged cells have a decreased amounts of or decreased ability to produce the chaperones, which are needed to fold the proteins. So the folding process also will be defected with the aging. So these are the three mechanisms of cellular aging: accumulation of damaged DNA, decreased cellular replication, and defective protein homeostasis. In this slide, we will repeat the mechanisms of cellular aging that we already discussed. The first one is accumulation of mutations in the DNA due to environmental and metabolic insults, reactive oxygen species, radiation. All of these will lead to accumulation of mutations, and with aging of the cell, its ability to repair this damaged DNA will decrease. This will lead to decreased cellular function and cellular loss, which will lead to cellular aging. The second mechanism is decreased replicative ability of the cell, decreased cellular replication, and the cause is usually, as I said, is the shortening of the telomeres at the ends of the chromosomes due to the non-function of the telomerase enzyme with the aging of the cell. This will lead to this that the cell will be arrested in the cell cycle and will not replicate, and sometimes will lead to cell loss. The third mechanism is by affected protein homeostasis with decreased protein synthesis, increased protein degradation, improper folding of the proteins. This will lead also to a decreased functional capacity of the cell and cellular aging. So let's emphasize more on the telomeres. Telomeres are short, repeated DNA sequences at both ends of the chromosomes. They are present there to ensure complete replication of the chromosome ends without damaging to the DNA, the coding DNA material at both ends, so to protect them. But the problem that these telomeres, they get shortened upon replication of the cell with bouts of replications, like in the aging process. Now, the shortening of these telomeres will signal the cell to enter into cell cycle arrest. Now, this telomere length is maintained by telomerase enzyme, but also this telomerase enzyme is expressed in high levels in germ cells, but in low levels in stem cells. However, it's not present, it's absent in most somatic cells. That's why the somatic cells enter the replicative senescence very early after few divisions. Now, this telomerase activity is reactivated in cancer cells, so they continue to divide in a limitless number of divisions. So let's see here the yellow color coding area of the yellow color short repeat of DNA at both ends of the chromosome are called the telomeres. And as you can see here, these are short repeats of nucleotides. The telomerase enzyme is important for maintaining these telomeres. If we have a reduced amount or reduced activity of the telomerase enzyme, then these telomeres will be shortened in every division cycle. So at the end, we will get a very short telomeres, and this will signal the with repeated cell divisions and with aging of the cell, and this will signal the cell to go into cell cycle arrest. So there will be senescence of mature cells and tissue aging. And as I said, telomerase activation will be seen in cancer cases in which the replicative ability will be maintained forever in the cancer cells due to the acquisition of telomerase activity. So you can see here that the telomerase enzyme is expressed in high levels in the germ cells and in low levels in stem cells, but it is not, as I said, expressed in somatic cells. That's why the somatic cells, after with the increasing age and repeated few cell divisions, they will enter the cell cycle arrest. بينما الستم cells ممكن ياخدوا وقت أطول عبين ما يدخلوا بالcell cycle arrest because they have a much higher amount of telomerase enzyme. But as you can see here, if the cell is transformed into a cancer cell, then the telomerase activity is turned on and the cells will continue to replicate unendlessly. The defective protein homeostasis that occurs with aging, I already discussed this, is due to increased turnover and degradation of proteins with the aging of the cell, decreased synthetic ability of the cell, defective activity of chaperones and the proteasomes, with decreased folding of the proteins, overall decrease in intracellular proteins. And accumulation of misfolded proteins can also trigger the apoptosis of the cells. Now that we talked about the aging, what are the anti-aging mechanisms? The precise mechanisms underlying these effects of these anti-aging mechanisms remains to be defined, but it is some well known that calorie restriction, physical activity, all of these have an anti-aging effect on the cell capacity. And also persistent inflammation, chronic metabolic diseases like diabetes, for example, hyperlipidemia, all of these will accelerate the aging process.